Hello everyone, welcome to our week 6 case study. We are in our final case study of the course, so let's get started. We have Sarah, a 20-year-old female whose friend suggested she come in and get help. She admits that for the past year she's been binge eating, followed by self-induced vomiting. She's been feeling out of control during the episodes, has associated shame and guilt. She shares that sometimes she'll order an extra large pizza and eat the entire thing by herself before vomiting. Self-induced vomiting. Sarah admits the behavior started when her longtime boyfriend broke up with her. Since then, she's had preoccupation with her weight, fear of gaining weight, and preoccupation of thought towards her body shape. She's noticed a significant impact in her social life and academic performance. She denies substance use, any SI or HI, denies hallucinations, any associated paranoia, and her physical exam shows that she's 5'7" and 140 pounds. For subjective assessment, we still need to get a full psych review of symptoms. So from this case study, we still don't know about any mood symptoms, anxiety, panic, any associated maybe OCD symptoms, past trauma, current trauma, any sort of somatoform disorders we should be aware of, and that also includes those somatic illnesses as well. Any cognitive disorders, associated ADHD, maybe comorbid, right? Attention disorder, any personality disorder symptoms, and any sleep abnormalities. We do know from the case information that she denies psychosis, she denies suicidality. It would still be important to assess any past suicidality. And then substance use, she denies at present. Again, important to get pertinent past psychiatric history as well. You really want to find out her family's psychiatric history and her social history. How does she use social media? What is her relationship like with her family, with her friends, her support system? And then we want to know for these patients past medical history. For example, we want to know if there's any history of a primary care provider or any other provider diagnosing her with esophagitis, dehydration, cardiac abnormalities, any associated diarrhea or constipation. That would come into play if she uses laxatives or enemas potentially with rebound symptoms, any menstrual irregularities as well. Then, to make an accurate diagnosis and be able to rule out other potentials, we need to find out about her eating habits, the eating patterns, the control that she has over those patterns and habits. What setting does her behaviors of binging take place in? Is it in private? Does she eat amongst others? What's the frequency, specifically within a week, of her initiating or self-inducing vomiting behaviors? From this case study, we still don't know about any food restriction, calorie counting, laxative or enema use, or her exercise habits, so we need to inquire about those as well. In our objective assessment, obviously vital signs. We have her height and weight from the case study. Her BMI is 21.9, which is in the normal range. We would do a physical exam, specifically look for this patient for dental erosion. We need labs, CBC, CMP. We need an EKG potentially for this patient. If all of her other physical exam findings come back to be normal and her BMI is within the normal range, you could potentially put off the EKG, but it's still important to refer her to primary care for follow-up as well. And then your MSC comes into play here. So screening tools to be utilized for primary care settings to identify eating disorders in patients, you could utilize that brief 5-question SCOFF. And then relative to this case study, you could use the EDEQ. The CIA should be administered immediately after the EDEQ. So the EDEQ will provide measures for the cognitions and associated behaviors, and then the CIA will help to assess those secondary life impairments or the severity of those secondary life impairments. You can utilize the ED15 in conjunction with CBT sessions being performed. The EPCL is great to track weekly changes in cognitions and behaviors. The CPQ will examine any associated symptoms of perfectionism. The DRI will assess any sort of dietary rules that your patient is following or any associated psychopathology with their eating disorder. And then outside of this case study, not relative to the patient that we have, but there's also the PARDI, there's also the NIAS, and the SSI, but we don't know any sort of symptoms of food restriction for this patient in order to suggest utilizing those screening tools. For our diagnosis, she does meet criteria for bulimia nervosa. We do need more information in order to address the severity, most likely mild based on what we're getting from the case study, but we need to know the frequency of vomiting per week, the frequency of binge eating and then self-induced vomiting per week. So she meets the criteria because she has suggested she has recurrent episodes of binge eating. She meets the discrete period of time for food intake, which is larger than a normal amount. She has a sense of lack of control during those episodes. We know that she does engage in an inappropriate compensatory behavior of self-induced vomiting. We also know that she has been preoccupied with her body shape and weight. And from what we know, the disturbance is not occurring exclusively during an episode of anorexia nervosa. We don't know anything about food restriction for this case study. The one thing we do still need more information on is we need to find out if the binge eating and the compensatory behaviors are occurring at least once a week for a duration of 3 months for this case study. We need to find that out still from our assessment. However, we can still rule out our associated differentials because of the following. So you can easily rule out because of her associated inappropriate compensatory behavior of purging, binge eating disorder. And you can also rule out MDD if you were using that as kind of your sole diagnosis because she has expressed excessive concern for weight. So the excessive concern for weight plus the inappropriate compensatory behavior of purging guides you away from MDD as your main diagnosis, right? She could have comorbid depressive symptoms, but we don't know that from this case study information so far. We would need to assess further for that, where she does meet currently the criteria for bulimia nervosa. Then we can also rule out from not having enough information borderline personality disorder or anorexia nervosa, specifically the binge eating purging type. So that brings us to treatment and goal setting. So severity always guides the level of care that is necessary for patients with primary or main diagnoses of eating disorders. For this specific case study, the goals would be to reduce or stop binge eating behaviors, reduce or stop compensatory behaviors. For this client, it would be self-induced vomiting, but from our assessment, we may have found that she was misusing laxatives or exercising excessively, and then improving her thoughts around body shape and weight. For this patient, we know she's low severity from the information presented, so outpatient management. She would be a great candidate for CBT. She could also benefit from interpersonal psychotherapy for eating disorders. They have group IPT as well. Or for patients who are a low severity level with potentially limited psychotherapy resources, then you could suggest guided self-help books. Be careful with what you're choosing, and I would always leave that up to the provider to guide that, not necessarily the patient just being left to themselves to choose what to utilize. So maybe review some different resources that you could suggest for patients. outpatient. And then DBT is beginning to show promise for bulimia nervosa and for binge eating disorder. Still limited studies on that. And then that brings us to medication management. So in conjunction with psychotherapy for bulimia nervosa, specifically Prozac is FDA approved. Also, off-label reduction in binge eating and purging has been found with Celexa, Zoloft, Luvox, amitriptyline, and Topamax. If you're thinking just about binge eating disorder or treating that specific symptom set based on the frequency for which this patient does binge eat and then potentially purge afterwards, Vyvanse might be appropriate for this patient. You need to find out the frequency of the binge eating and then the frequency of her purging behaviors. But Vyvanse is FDA approved for binge eating disorder. Considerations specific to this case study: the time of day for a patient with bulimia nervosa that you want them to be taking their Prozac would be at bedtime, or their antidepressant or any associated psychotropics or medications, honestly. You want it at bedtime because you don't want absorption to be interfered with by their purging behaviors. The dosing would be higher than normal, follow the treatment guidelines for OCD potentially. And then specific to this patient, you want to avoid Wellbutrin, lithium, and Remeron. Other medication management would depend upon your associated assessments, and that would guide any adjunctives from that point forward. You all did wonderfully on this final case study from what I was able to read in our discussion board, so great job. Thank you all.